Point out that the reason I'm so productive is because I'm very old. But it's nice to be giving my first talk in Latvia in my 70s, so thank you for the invitation. And there on the front you see the my latest book, which happens to be on the title of the topic I'm talking about today. Interests, well, I have an interest in the charity I set up, Drug Science. I advise a couple of companies in the field of psychedelic space. So let's start off with discussing what psychedelics are. And they're largely molecules which have been derived from plants and fungi. I would say they're probably the oldest pharmaceutical agents. It's almost certain that all human cultures, when they started finding things to eat, came across magic mushrooms or cacti, did a psychedelic. And if we go around here, we see mescaline-containing cacti from Americas, magic mushroom-containing cacti all over the world. This here is the first known image of a psychedelic piece of psychedelic art. It's 7,000 years old, and it's in Algeria. And it's pretty hard to imagine anyone would have come up with this kind of mushroom man who hadn't taken a magic mushroom. Over here we have ayahuasca, which is a very interesting cocktail of two plants, one of which contains DMT, dimethyltryptamine, and one of which contains harmaline, a monoamine oxidase inhibitor that allows the DMT to be absorbed without being broken down by the liver. And then we have down here actually, I should say Northern European, definitely very common in Latvia and the Baltic countries. It's Amanita muscaria. It's a very different kind of psychedelic. It's a GABAergic psychedelic. The active ingredient is muscimol. And I won't be talking much more about that. But I just wanted to point out that it was well known in Roman times because there's a Roman mosaic telling you how to make it. Just boil the mushrooms up in some tea. India, the origins of Hinduism, are clouded in history, but best evidence we have is that the visions that were achieved by their gods were derived from a cocktail likely made of, they called it soma, and it was likely made of cannabis, magic mushrooms, and ephedra. Sorry, I'm just trying to turn my phone off so we can get through this without more disturbance. Sorry about that. And on the left-hand side, you have perhaps the most important image. This is a Greek vase. It's 3,000 years old. It shows the Greek god of agriculture, Demeter, partaking of ergot on rye. The Greeks developed a drink which was a cocktail of wine and ergot, which they used to fuel what were called the Eleusinian Mysteries. And these were celebrations of art, music, dance, theatre, poetry, which occurred every time the ergot grew on the cereal crops. And those lasted for about 1,500 years, and they were so good that the Romans carried them on when they took over Greece because they enjoyed their behaviors and insights. And here's the Greek god, here's Demeter sharing magic mushrooms with her daughter Persephone. And you'll also notice that I've made comments about churches and religion all through this. And actually, this is a talk that I gave to the Vatican last year, trying to help people understand the value of psychedelics, not just in terms of psychiatry, but also in terms of spirituality, which I won't talk any more about now, but I can in questions if you want. Now, the big breakthrough in the modern era came with this man, Albert Hofmann, who was working on ergot, trying to find essentially new patentable products from the ergot plant. He made a number of them. He made 25 of them, in fact, at least. But the one, lysergic acid diethylamide, LSD-25, turned out to be rather different from the others. It produced powerful psychedelic experiences, which he wrote about, captivated the scientists and doctors around the world, and became massively studied. And here's Albert, and it's his 100th birthday, sitting here in his villa overlooking Lake Geneva, and he lived to 102, and he took LSD on a regular basis in low doses, which may explain his longevity. Because of the interest in this drug, and because there was nothing else available for psychiatry at the time, it became massively studied. There were 140 US NIH grants, 1,000 clinical papers, 40,000 patients were studied, 40 books, 6 international conferences. And in 1971, when these drugs all got banned in the UN Convention on Narcotics, Masters and Houston wrote that these results were overwhelmingly positive, describing safe and effective treatments. So what was LSD and psilocybin used for? Well, they were used to model psychosis, to try to get a handle on what's going on in the brain. They were used by mental health professionals. Often they were given to junior psychiatrists early in their training so that they could experience what it would be like to have altered consciousness and therefore make them more empathetic with their patients. And they were used for psychotherapy. And there were two kinds of therapy. Psychedelic psychotherapy was pretty similar to what we do today. A high dose, single dose, people have a trip and they come out of the trip changed. And this was very much favored in the US. In the UK, we were a little bit more cautious, and we did what we would now call psycholytic psychotherapy. We gave low doses, non-hallucinogenic doses, before each psychotherapy session. The idea being that you can break down unconscious resistance and therefore engage better in the therapy. And today we're doing something similar. So on the top right here, you see a study we did. We modeled psychosis in healthy volunteers with psilocybin, and we saw if we could block it with a drug called saracatinib. Now, that's an anti-cancer tyrosine kinase, but it gets in the brain and it blocks some of the effects of saracatinib, of psilocybin. And because of that, and because it's a non-dopaminergic agent, we're trialing it now in Parkinson's disease psychosis, where you cannot use dopamine blockers, and it's shown to have some impact on the perceptual disorganization in Parkinson's disease. Down here with psychedelic psychotherapy, the approach, as I said, is mostly to use a high dose, a single high dose, and that's 25 milligrams of psilocybin. What about psycholytic psychotherapy? Well, we're starting that now. We've just completed a study of a 10 milligram dose of psilocybin given for patients with OCD. Now, we thought they would benefit better from a trip dose to break down those internal ruminations that underpin OCD. But our patients said, no, we're not going to do that. We don't want to lose control. So we agreed on a lower dose, but this dose still has powerful subjective effects. It helps people reappraise their attitude to their symptoms. And we found quite good responses. And that paper is now under review. So this may be a promising alternative treatment for OCD. And we're also now using a lower dose in young people who self-harm, who cut, because there is growing evidence that psychedelics can increase people's ability to think differently. And there's a program we're developing, or my colleague Martina Di Simplicio, who's the senior lecturer at Imperial, is developing to help young people who cut do something different when they get the urge to cut. And we're trying to train them in cognitive reframing. And we think that a low dose of psilocybin may help them do that. We have ethics for that. We're just about to start. But I've already intimated there was a problem. The massive expansion of research in the 1950s and 60s with psychedelics, particularly LSD. And psilocybin, by the way, was also discovered. The structure of psilocybin was discovered by Hoffman in 1956, and he realized it was similar to serotonin and to LSD. And Sandow made that available for research too. But LSD got out into the public use, and these protests against the Vietnam War were extremely threatening to the US government. They couldn't ban war protests, but they could ban acid. And that statement, drop acid, not bombs, was so oppositional to the US way, and in fact, the international community's way of doing politics at the time, that they wanted to get it stopped. So they banned LSD. And they hated the idea that people might make love, not war. And psychedelics unquestionably reduced people's desire to hurt other people. So they banned it, and the ban occurred here in America, and then because America controlled the United Nations, it occurred here in 1971 around the world. And there was a cataclysmic fall-off in research in 1991 and 1994. There were no published citations at all for psilocybin. And in order to, I think, to deliberately eliminate knowledge of these drugs, they were put into Schedule 1 of the UN conventions, and alongside drugs like crack cocaine and crystal meth. And they was therefore, the world was told that these drugs were very dangerous, had no medical value, which obviously was ridiculous because there was 1,000 papers published before, and they were addictive, which was also ridiculous because they've been shown to treat addiction. So this was a deliberate censorship of patient access in order to pursue and promulgate the myth that these drugs were really dangerous. And this was a political decision, and it worked, because it certainly stopped people working on them. You can see that it became virtually impossible to get these drugs for scientific study. And it's the worst censorship of research in the history of the world. And it's also the worst censorship of clinical therapy, I believe. You could estimate that probably tens of millions of people with depression, suicidality, PTSD, addiction have died because they couldn't get access to a treatment that might have cured them. But in the last 20 years, we've been fighting back, my group and others, and we've been fighting back from a knowledge of what these drugs do. And the first thing to say is these drugs work on the serotonin 5-HT2A receptor. So this is a receptor, as you possibly know, it's a G protein. These are the G proteins. So here's the 2A receptor, and there's the binding site for psychedelics here, outside of the cell membrane. Now, a whole range of psychedelics, from LSD here to mescaline here, they're all agonists at the 5-HT2A receptor. In fact, their clinical dose is completely predicted by their affinity at the receptor. LSD, very high affinity, very low dose, very potent. Mescaline, low affinity. Might need up to a gram of mescaline, you need 100 micrograms of LSD. And psilocybin and DMT here as well. So we know they work on the receptor. They bind to other receptors, but those effects are peripheral. And we know that because 5-HT2A antagonists like ketanserin, risperidone, mirtazapine, they block the effects of psychedelics. Now, the 2A receptor turns out to be a very interesting receptor. So on the left-hand side, you have a heat map of the density of these receptors in human brain. And on the right-hand side, you have a heat map of the evolution of the brain, with red being most recently evolved. And you can see there's a remarkable overlap. The 5-HT2A receptor is massively expressed in the parts of the brain which have evolved to distinguish the human brain from the primate brain. And those parts of the brain we now call the transmodal cortices. And they're the parts of the brain in which humans do all the very human mental activities: thinking, analysis, planning, reflecting, self-absorption, etc. And we don't know why there are so many of these receptors in those parts of the brain, but we've put a paper out recently suggesting maybe the patterning of the human transmodal cortex, with its phenomenal sophistication in terms of creating constructs of the world, has got something to do with these receptors. And you'll notice there are very few of them in the brain stem and the midbrain, and that's one of the reasons these drugs are very safe. They don't interfere with primary physiological processes, and there are very few in the areas like the nucleus accumbens. They don't cause addiction because they don't mess around with the dopamine system. And it turns out they're located on, not completely, but very highly expressed on a particular set of neurons in the cortex. And these are called the layer 5 pyramidal cells. Now, for those of you who want a very simple perspective on the human brain, essentially the human brain is a collection of about 80 billion computers. These are called pyramidal cells. They align perpendicular to the cortex. And each of those is a cortical column, and that cortical column is a computer. The primary computing is done at right angles to the cortex, but the secondary computing is done because these layer 5 pyramidal cells connect with thousands of others across the brain. They produce the integration of brain function that makes the human brain such an amazing machine, a computer-like, because you've got billions of computers working in unison. In fact, the human brain has more computing power, it's been estimated, than all the computers on Earth today. And when you stimulate those receptors with a psychedelic, the neurons depolarize like crazy. And that depolarization is the reason you have a psychedelic experience, because you change the ongoing, routine, entrenched processes of the brain. And here's an example of how we measure that. So these are brain prints. They use a technique called EEG, magnetoencephalography. The frequency domain is the same as EEG, low frequency delta, high frequency gamma. The color coding, red means increased power, blue means decreased power. And if you look in the right-hand side, you've got a box here with ketamine, psilocybin, and LSD, and they produce profound alterations of consciousness. And what they do is they reduce the power, particularly in the frequency bands up to 30 hertz. Massive reduction in power. And that is a desynchronization of the brain. That's the psychedelic state. And we call that the entropic brain. The brain is much less organized during the trip. On the other side here, you have drugs that work on the GABA system. Zolpidem, a sleeping pill, works largely in the cortex, because that's where the alpha-1 receptors are. Gaboxidol, an extrasynaptic GABA agonist. Tiagabine, a GABA uptake blocker, produces profound alterations in consciousness, deep power in the slow waves. People go into a cataleptic state. And propofol, an anesthetic. That takes out the high-level gamma frequencies, which is why you're unconscious. So you can see fundamental differences between sedative drugs and psychedelic drugs. And by the way, alcohol is in the middle. It's a bit more sedative than psychedelic, as you might imagine. And perampanel, by the way, is an AMPA antagonist, which is used in epilepsy now. So what happens when you image the brain under a psychedelic using fMRI? And this was the first ever brain image of a psychedelic state using fMRI. And we published it 13 years ago now. And it illustrates really the fundamental disruption that psychedelics do in terms of a particular brain circuit called the default mode network. Now, the default mode network was only discovered when we had brain imaging. And I'll explain it to you. Some of you may know it, but please bear with me, because not everyone does. The default mode network is a network which a network of neurons that fire together. It's this prefrontal network here, posterior cingulate, and these two lateral parietal networks. And these all work together in harmony. And it's called the default mode network because when you're sitting quietly, when you're not listening to anything, you're not moving, you're not seeing, you have your eyes closed, when you're just reflecting on yourself, that is the dominant network in the brain. That is the network in which you code your sense of self. That's where your ego is encoded. And probably if you're spiritual, where your sense of spirituality is encoded. It's where you do your thinking about the past, the present, and the future. As soon as you open your eyes or move your arms, the default mode switches off and these other networks come in. But when you're sitting quietly, the default mode is the dominant network. Under psychedelics, the default mode network is completely disrupted. It doesn't exist anymore. You see, it's gone. Some of these areas have become anti-correlated. And the alterations of time and space and self-perception which occur in the psychedelic trip are directly correlated with the disruption of the default mode. Your ego is disrupted. And that can be very useful because if your ego is working to harm you, for instance, if you have very negative thoughts in depression, you can break those down. Now, the breaking down of the default mode, which is in some ways you can see this as the orchestra, the conductor of the orchestra of the brain. The breaking down of that leads to a very different state of connectivity in the brain. On the left-hand side, you have the normal brain, which is called the small world brain. On the right-hand side, you have the brain under psilocybin. They both have the same number of connections, 7,200 connections in each. And these connections are statistical connections. They're likelihoods of one particular voxel in the brain firing when another does, or firing, having their bold signal change alongside with another voxel. On the left-hand side, you see most of the activity, most of the connections are on the periphery. This is called the small world brain. The visual cortex talks to visual cortex, auditory cortex talks to auditory cortex. Of course, if you hear a bus bearing down on you, you've got to get your legs moving. You've got to have some connection between auditory cortex and motor cortex. But there are relatively few long distance connections made in the normal human brain. And that's because the brain is massive compared with a neuron. And the energy costs of these massive communications, thousands of times further than the neuron's cell body, is very high. So the brain is very efficient because it downloads most of its activity to peripheral regions. And your brain is, in fact, 10 times more energy efficient per unit of information transfer than the best human computers today. And that's fantastic. Learning certain things very precisely and remembering them and having them reproducible is very important. The fact you can all understand every word I've said in terms of the meaning, anyway, if not necessarily the content, is because your brain is becoming it's a superbly efficient word learning machine. And you learn most things to good effect. But suppose you learn something that is actually not ideal. Suppose you learn, you start thinking you're a bad person, and you start to think that, and you keep on thinking that. Maybe you're told that when you're abused by your father, and he tells you it's your fault, you seduced him. And you have that thought, that guilty thought. And that thought runs around your head thousands of times a day and thousands of days in your life. That thought becomes deeply, deeply entrenched. The only way to get you out of that is to break down the ground in which that entrenchment is made. And that's what happens with psychedelics. Put the brain back to a state before deeply entrenched thought processes took place. It's the only way we have of helping reset the brains which have become, have developed thinking processes which are maladaptive. And that, I believe, is why they allow people to escape from disorders like depression. We've also studied LSD, and again, people see things differently. Under psychedelics, people see themselves differently. They don't just see the world differently, but they see themselves. And that's because LSD massively enhances communication across all the brain, whereas normally, this is just looking at the visual system connectivity, it's very limited. This is the small world brain, this is the psychedelic brain. You can see everything in your brain. You can see your past, your present, your future, etc. And it were those images that encouraged us to move into translational medicine, particularly in the treatment of depression. Obviously, it's a massive problem because it's the #1 disability in the Western world. Treatments fail in about a third, and it's massively increased prevalence in young people. So what was the justification for studying psychedelics in depression? Well, this was an image from our very first study. What you see here is a reduction in blood activity in the this frontal part of the default mode, but particularly this region here. And this region is the subgenual cingulate cortex. And when we saw this image, it reminded us of the fact that many treatments of depression are associated or rely on a reduction in activity in this region. So SSRIs dampen it down, CBT dampens it down, sleep deprivation dampens it down, ECT dampens it down. And remarkably, if you get better on placebo, as Helen Mayberg showed, that is there's a correlation between improvement on placebo and a reduction in activity in this region. And that's why she went on to develop deep brain stimulation for depression. She switched it off with DBS, and people got better. And subsequently, Bill Deakin showed that ketamine did the same. So we thought, wow, all these different treatments of depression have one thing in common. They all reduce activity in the medial prefrontal cortex. Well, we can do that within minutes of giving psilocybin, whereas it might take months with CBT. So we thought, well, maybe psilocybin will lift depression. And then also, in an interesting coincidence, at the same time as we were doing that first imaging study with psilocybin, this group from Yale were publishing this study. And they were looking at the extent of default mode engagement in the brain, the volume of the brain engaged in the default mode in depressed people compared with healthy controls. And you can see the depressed people have much more of their brain is engaged in this self-reflective thinking. And that explains why depressed people struggle with executive tasks, because they've got less brain to do the executive tasks. The more of their brain is consumed with other things, the rumination. And there's a very strong relationship between rumination here and the correlation between the default mode network and the subgenual cingulate driving that. So we thought, wow, there's too much default mode in depression, which makes sense. Depression is an internalizing disorder. People are ruminating about themselves. We can destroy that, break that down with psychedelics, so maybe it will disrupt depression. How do we do this work? Well, we have a very regular, systematic process now. In essence, when people are eligible, they're assessed over the phone usually. And then if they're eligible, they come in the afternoon before they're going to have the trip. And there they meet the therapists, and we call them guides, and then we talk them through what a trip might be like, how best to deal with the experiences. We get permissions to hold their hand if they ask for it in case they get scared, etc. And then they stay overnight, and the next day they get the psilocybin trip, and for our studies, there are always two guides present. One is medically trained, and the other is someone who's learning the skills. And then we don't do any therapy during the trip. They have eye shades, they have ear microphones, and they listen to a soundtrack if they want. And we ask them to just go where the trip takes them, not fight it, but just go where it allows you to go. And it surprisingly goes to things that they've often repressed or have not actively been able to deal with. And then the next day, after the trip, they come out, and then the next day they meet with their guides, and we start a process we call integration, which is helping them use the experience of the trip to essentially set themselves on a new way of thinking about them, the past, the present, and the future. And where we can afford it, we carry on with psychological support, and where we can't, they have to go back to their therapists or their GPs. And this is a study we published in Lancet in 2016. So this was a remarkable study. All these people, these 20 patients, they'd all failed on 2 antidepressants. They'd all failed on CBT. Some had failed on over 10 antidepressants. And they all were given a single trip, 25 milligram trip. And you can see there's dramatic reduction in depression scores. And that persisted and actually reached its maximum significance here out at 3 weeks. But it was still very significant, even at 3 months. And that is the most powerful single-dose treatment of resistant depression in history. That paper has been cited 1,700 times now, and it's initiated, or sparked over 10 companies being set up to work with psychedelics for depression. And we recently did a Bayesian analysis of that data. And what you see here is that if you take a flat prior, so you're neutral about whether it was going to work or not, another patient with the same diagnosis put into the trial would have an over 80% chance of recovery. And that's seriously powerful medicine. Now, since then, there have been massive replications This is a huge US multi-center study. This is a Johns Hopkins study, which is psilocybin versus waiting list control. This is an international study, some using ayahuasca, some using LSD, etc. This one is the most important one. This is the Compass Pathways trial, and some of you may be part of that, or have been part of it. And it's essentially the same as we did, a 25 milligram dose of psilocybin, producing remission in about a quarter of patients at 12 weeks. But it's a dose-response curve, so it's very interesting. It shows that the lower doses, you get some improvement due to the therapy, the psychotherapy, but there's nothing like as powerful and persistent as the high dose. So it's the psychedelic experience that drives the outcome. And there are studies also in other disorders. There are two very interesting studies from Johns Hopkins and New York University of people with end-of-life anxiety and depression, with cancer or terminal diseases. There's people, Johns Hopkins have done a study of smoking, helping people stop smoking. Schutz has done a trial of alcoholism. There's a trial in Switzerland of LSD in generalized anxiety disorder. And there are others on the way in anorexia, OCD, pain syndromes by our group and others. And you might say, well, it doesn't make any sense, does it really? I mean, these are all different disorders. But there are two aspects of that, which I think explains why psychedelics can work. The first is they're all internalizing disorders. They're all disorders in which the cognitions are self-referential and ruminative. And they're all encoded in the default mode network. And the second is that they're all disorders of networks. And disrupting networks, I think, is the future for helping patients recover from mental illness, because it's almost certain that almost all mental illnesses are network disorders. So here's a little summary of what I've told you so far. This is a review we wrote a couple of years ago. We're targeting the 2A receptors in the brain. They're on these pyramidal cells. When the psychedelics stimulate them, there's a massive depolarization. That changes the frequency of the brain to this high entropy, the very, very random brain activity. That leads to increased connectivity in the brain, which changes the way people think about their past and their present and their future. But on top of that, unexpectedly, preclinical scientists have discovered that psychedelics increase the plasticity of the brain. And they do it by increasing the number of dendritic spines and also the number of synaptic spines. So the brain, after a psychedelic, and for animals, many weeks, maybe months, the brain is in a better state to learn things. So the new insight you get here can be laid down and hopefully turn into an enduring way of thinking more positively about your past, for instance. Now, proving neuroplasticity in humans is actually something we're trying to do. It's much trickier than in a rodent. You can't cut the brain out and stick it under a microscope. But certainly we've got evidence of increased flexibility in the brains following treatment, and we're trying to measure synaptic density as well. And the evidence we have for increased flexibility comes from the fact that we've now done 2 psilocybin depression studies. And this was the first one, and these data are derived from the brain imaging done before and then 1 day after the psilocybin trip. We don't ever scan patients during the trip. We think that's unethical because it could interfere with the value of their experience. When we scan patients a day after the trip, we discovered that their brain was more flexible. This is a measure of what's called brain modularity. It's how easy it is, how frequently the brain flips between different states of activity. And the modularity breaks down or is reduced following the day after the trip. And that reduced modularity, you can see here, the default mode network becomes less engaged with itself and becomes more engaged with other networks, like here you see the executive network, here you see the salience network. And that breakdown in modularity predicts outcome. It predicts outcome at 6 months. And that actually is, wow, I mean, it's hard to know anything in psychiatry, where something happening a day after a treatment could predict long-term outcomes. So that's very exciting. And it fits in with a theory that we've been developing now for about the last 10 years. And this was its first publication. We suspected, and I think we now pretty sure it's true, that there were two ways to live depression. The traditional way is to use drugs like SSRIs. SSRIs increase serotonin in the limbic system. The increased serotonin works on a receptor called the 5-HT1A receptor, which is an inhibitory receptor, and that therefore dampens down limbic activity and limbic responsibility. Depressed people have supersensitive limbic systems. They're much more responsive to stress, and that chronic response to stress is actually what disables them and makes them depressed. They feel they don't have autonomy or the ability to deal with the stress. So SSRIs dampen that down, and that reduces stress, but it also reduces impulsivity and aggression, but also anxiety, and that's why SSRIs are good for anxiety. But the problem is that you don't just blunt the stress response, you also blunt the positive response. People feel they don't enjoy life as much. They're not as depressed as they were, but they're not as happy as they were as well, or they're less happy. Psychedelics work in a different part of the brain, in the cortex. They work on the 5-HT2A receptor. You stimulate those receptors, that massively increases the entropic nature of the brain, that breaks down rigid, inflexible thinking and perseveration, leads to cognitive flexibility, and that reduces depression, but also increases well-being, because cognitive flexibility is really critical for dealing with life. You have to be able to adapt to what the slings and arrows that life throws at you. And to me, this is really exciting. Now we have a situation where depressed people have an option of two different kinds of treatments. Our depression's on a par with cancer and hypertension. There are different treatment options. If one fails, there's something else you can try. I want to say a little bit about MDMA, because that's another area of great interest, another drug which was made illegal. It was made illegal in the 1990s because young people were using it and having fun. There was no real evidence of great harm, but it was seen as promoting social disconnection between the young and the old, because the young were having fun and the old weren't. So it got banned. This is Sasha Shulgin, who rediscovered it. And this is his wife, who was a psychotherapist. And she realized that MDMA could be really powerful in helping couples come back together. It's called the love drug by kids, and it can be used to put love back into relationships, so she found. And it was being widely used in psychotherapy until it got moved out into recreational use in clubs, and then it got banned. But now it's back, and it's back because it has a very interesting pharmacology that makes it very useful for trauma disorders. So what does MDMA do? Well, MDMA does this. MDMA releases neurotransmitters. It particularly releases serotonin, but it also releases some noradrenaline and dopamine. And it partially blocks the reuptake of them. So it massively enhances serotonin in the synapse. And it's preferential for serotonin. Here you see some data of ours showing you get maybe 10 times more serotonin release than dopamine and noradrenaline release. And that's hugely important because that serotonin release explains why it's not addictive, why it's not cardiotoxic. It may also explain why it's anti-addictive. And I just want to emphasize this because there's an awful tendency for people to say, well, it's a variant of methamphetamine. But the reality is, in living animals, in vivo, that should say, MDMA has 5 times less effect on dopamine than serotonin, whereas methamphetamine has 15 times greater effect on dopamine than serotonin.
Professor Nutt, I am very sorry, but can we have a chance to leave a couple of minutes for questions? We would love to ask a couple of questions.
Oh, sorry, I thought I had 40 minutes and then 20 for questions, so I got it wrong. I apologize. Okay, I'll stop. Okay, well, there's been a huge interest in the use of MDMA for PTSD because of the Iraq and Afghanistan wars and because of all the damage to civilians all the way through the Middle East and elsewhere. There's good evidence that MDMA works in PTSD when it's added to psychotherapy. We know how it works. It suppresses the emotional centers and allows patients to engage in therapy better. And there's a little review you can read. I've sent the slides. You can all have the slides, okay? It also works to help people reduce drinking. And I'll finish now by saying that psychedelics change the way our patients think about themselves and allow them to escape from the problems of things like addiction and depression and PTSD. And Australia has already moved. Australia has already rescheduled psilocybin and MDMA for treatment-resistant depression and PTSD. And Canada is doing the same for end-of-life disorders in some people. So it's something that I would encourage everyone to do. And if you want, you can see the Vatican lecture here on that link. Thank you.
Thank you. Thank you. Thank you for your knowledge and for your experience. Okay, ladies and gentlemen, we have time for a couple of short questions. Yes, please.
Yep. Yeah, well, thank you. I just wanted to ask about the age of the participants of the research. What is the age range in most of these research, and does the age affect the effectiveness of the treatment?
It's a great question. Actually, the 5-HT2A receptor becomes somewhat less sensitive as you get older. Our age range, I don't know what the oldest one was, but probably pushing 60. But there's definitely a fall off of effect as people get older.
Okay, is there also another question?
Sorry, in terms of the psychedelic effect, I mean, we haven't got enough subjects to comment on the therapeutic effect yet.
Thank you very much for the wonderful lecture. I just have a question because it does really seem like psychedelics offer a very wide range of relief for a lot of mental health disorders. Do you have any information or maybe insight into how it could be applied to perhaps like psychiatric disorders like schizophrenia and stuff like that?
Yeah, I mean, we're very hesitant to even try it in people with schizophrenia. The brain signature, the entropic brain, is not so dissimilar to the brain signature in people who are floridly psychotic. And then historically, we know that people who were schizophrenic taking LSD generally didn't do them much good. I mean, some did, but most didn't. So we always exclude anyone with a history of psychosis, and certainly current psychosis from many of our work. And there are other groups who are thinking, well, maybe we're being too cautious. What they are thinking of doing is using low doses, perhaps the psychoplastogen dose, to see if they can improve cognitive function in schizophrenia and also in Alzheimer's. So it may be that we can use psychedelics in very low doses to promote brain growth and in higher doses to disrupt symptomatic networks that are problematic. There's going to be a lot more work over the next decade on this.
Thank you very much.
I should also say that they don't, for most antipsychotics, block the effect of psychedelics, which is good because it means that people who maybe take them to try to self-medicate for schizophrenia are largely not going to get an effect.
Can I have a question? These drugs do seem magical, but are there any downsides, or have you seen any bad outcomes of your patients as well?
Well, there are two aspects to that answer. Yeah, of course, all drugs have downsides. I mean, these drugs, in the right hands with the right care and professionalism, we haven't had any major downsides. But it's important to say that depressed people, PTSD people, people don't have, these aren't fun trips. They're not wandering through, the universe enjoying. They're actually dealing with really difficult, traumatic memories usually. So they often come out and say, wow, that was challenging, but at last I'm on top of my problems. So, but because of that, we're very strongly of the opinion that these are they're like surgical treatments. They're not something you do at home. They're something you do in a clinic with therapists present. And we absolutely require that there be at least 2 doors between the room and the outside, just in case someone gets very anxious and tries to escape. Now, we've not had that. We had it once in one of our volunteers, but we were giving him LSD in a MRI scanner, which is actually not a very pleasant place even without LSDs. But modern, carefully administered psychedelics do seem to produce good outcomes without much in the way of any problems. But in the real world, obviously, probably about 10% of people who are using them recreationally, particularly if they're using them in risky places like forests or sea cliffs or whatever, then some people come to harm and some people get anxious. So we recommend never doing it without there being someone not taking the drug near you, just to protect you.
Thank you. It looks like we are running out of time, but I cannot stop myself to ask my question.
Chairman's prerogative, go on.
Yes, and as somebody who is coming from science, from physics, I was very much impressed with these brain images, 3D brain images, which you showed us. And this reminded me something which was done by Richard Davidson in meditation stages. He also took a lot of images what happens during meditation. And my question actually consists from two parts. First one is, do you see any similarities with states what people have during meditation and during this intake of different drugs? But other questions may be a little bit different, but very strongly related to that one. We still don't know how our brain functions, from where our consciousness is coming, why we are feeling love, why we are feeling hate sometimes. What are the limitations? How far we can get with these brain images, and at what point probably they will become kind of limits which cannot be exceeded because we simply don't know how brain activities are related to our conscious experiences?
Yeah, well, great question. So the first one's easy to answer. Yeah, if you can take yourself into transcendental meditation, your brain looks like the brain under psilocybin. The problem is it takes generally 10 to 20 years to achieve that skill, whereas you can get it in about 10 seconds on psilocybin. And so, in fact, groups have been using psilocybin to facilitate people acquiring meditative skills. In a sense, they know where they've got to get to under the psilocybin, so they can practice going back there when they meditate. So, but yes, very similar, particularly in the prefrontal regions. The second question, yeah, absolutely really intriguing. How far can we get down into the human brain to estimate what's going on where? And the answer is probably not to the level that is going to be useful clinically. I mean, whether we can externally measure sufficiently small numbers of neurons in relatively small networks, because we're disturbing the whole brain, and somewhere in there's an abnormal network, but measuring that abnormal network is pretty close to impossible from outside the brain. But people are doing other things. There are people who are putting electrodes in the brain and recording from areas like in OCD, where you can see an oscillatory network which is abnormal, and then you can pulse it to be normal. But from outside, it's going to be pretty difficult. But people are working on it. They're trying to use sort of transcutaneous pulses of sound to turn on different areas of the brain. We might get there eventually, but measuring it, difficult.
Thank you. Let us thank Professor Nutt again.
Thank you.
Thank you.
Yeah,